In every field, neonatology ho jaye, endocrinology ho jaye, ID ho jaye, nephrology, there will be kids who will come in with unique features, and it is important that recognition pattern. So I'm just saying, it's very tough to teach. You can have a whole week-long course on dysmorphology. Okay? So I'm just going to talk bare basics. These talks can get a bit boring because it's picture after picture after picture with terms. I'm going to try to make it a bit interesting, and we'll take it from there, and we can obviously, like I said, do follow-ups, and there are many things that you guys can do on your own also to practice your dysmorphology skills. Okay? Again, no disclosures, and mainly चीज़ है कि terminology थोड़ी सी अजीब सी होती है, but it is very important to use the right terminology. I'll give you an example. I'm going to ask you a question, and it's usually a very bad term, but I want to ask this question from you guys. How many of you have either seen or used the term FLK? Please be honest. FLK. हमारे सीनियर कंसल्टेंट्स मुझे रिफरल पर लिखते हैं, रिफर टू सलमान किरमानी FLK. मेरा दिल टूटता है. फनी लुकिंग किड. तो इतना अच्छा है कि आप लोगों को पता ही नहीं है क्या चीज़ है. ये हमारा आधा काम तो यही हो गया, राइट? एंड आई टेल यू व्हाई. एक तो जाहिर इतनी घटिया टर्म है बिकॉज इट्स इंसल्टिंग, राइट? यू कांट टेल द फैमिली योर किड इज FLK, राइट? But there is an inherent ignorance in using it. You don't know what to say. You cannot describe what you are seeing. You don't recognize the pattern. So you use your term of convenience, which is obviously very bad. So the take-home message is, don't be ignorant of the term. The term is like, when you write, this child has coarse features, and you make a referral to the gastroenterologist, they will have a different set of differentials. You don't need to say this has this particular storage disease. No one expects that from you. But describe what you see. If you're referring to the neurologist and you can describe microcephaly or macrocephaly or whatever, you'll do a better job, you'll get a better output. So communication in our notes, in our verbal presentations is extremely important, and part of the talk is just to use the right terms, all right? And we'll talk a little bit about technology. So Dr. David Smith in the 1960s coined this term, dysmorphology, because again people were using non-specific terms and politically incorrect terms, so this was kind of used.
Yeah. This means what, morphology means what. Yeah. It's just breakdown. A lot of terminologies you have to just break down and extract the meaning.
Yeah. So morphology is how things are made. Dysmorphology is how they are mismade, or
not normal.
Yeah.
It's deviation from the normal.
Yeah. So every pediatric unit should have this book. And now we're switching over to electronics, so maybe at least an electronic copy or a PDF or something. And people are using Google Images, but Google Images has its limitations. It can give you wrong labels. So when you're making PowerPoints, everyone uses Google Images. Please verify the source, because you can put up the wrong picture with the wrong syndrome, right? So this is something that's still traditional. In my training, the thing was every resident had this book in their bathroom. So we would flip through the pages in the free time just to say कि भाई तस्वीर याद आ जाए, ताकि when you walk into a clinic, you write, oh ये तो उस page पे थी, या ये तो ये देखा था. And literally that was the only way, but thankfully things have improved. There are other things now. I kind of just use some examples. There are books that people can see. If you're still a book reader, most people are just now decorating the books with their bookshelf with their books. But if you are, but now this is the age of AI, and phenotyping can now be done by machine learning and by algorithms. And obviously, like any AI technology, it cannot replace you. You have to be the responsible, knowledgeable person to use AI to become more efficient, right? But this phase 2 gene technology is very, very cool. And what it is basically an app in the phone. Anyone can download this app. You can download it today. And you can basically take pictures of patients. It's done in a very private sort of way. Doesn't go on the internet, doesn't go on Google. And you take consent and you do it. And it will give you a differential diagnosis. I'm sorry, again, it's not projecting very well, but this tells you what the level of suspicion is and how much it matches. And basically what it does is it makes a heat map. And the only match it makes is from bona fide cases published in the literature. And the good thing is that unlike the traditional atlases that only had the European white people, these are pictures from all ethnicities, all ages. So you get a much, much more representative picture, and it's very, very powerful. And obviously, I have seen this app evolve over the last 10 years. When I used to use it in clinic 10 years ago, the output wasn't very good. And now that the algorithm is that much more powerful, so being used by so many people, It's actually led to a lot of successes. It really helps once you have a hypothesis. When you don't have a hypothesis and you're saying, yaar, dekho kya batayega, tab itna help nahi karta. But when you say, yaar, this kid looks like they have Williams syndrome, let me take a picture, and that also then is confirmed, it becomes a much better thing. So I'm saying this app is not your be-all, end-all, will not solve all your problems, but it is a good tool to have along with the knowledge, and we'll talk to you a little bit about that. Terminology, we'll go through some pictures, right? So this is just an example of what you would usually say is a broad face. Okay? There are other dysmorphisms, but I'm going to highlight the ones that are just being sort of the most characteristic in this, right? You can see that the face, the structure is rather broad. This is coarse. Now, how do you explain coarse to someone, right? It's a very, very tough term to explain. So the way I kind of understand it is the opposite of sharp. You know, well chiseled features हम कहते हैं ना जो sculptures में होते हैं कि जी nose बिल्कुल sharp and chin angle and everything. The angles of the face are blunted. And there's a reason why they're blunted, because the storage material is causing swelling of the cells and everything, and swelling of the tissues, and that's why you see the coarseness. So this is what coarse features will look like. This is a narrow face. Again, the point of these pictures is not, oh, this patient has this condition or this syndrome. First, learn to describe what you're seeing. Don't say, oh, this looks odd or this looks unusual. You should be able to process it and say, why does it look unusual, right? Why does it look unique? This is a triangular face, right? So you can kind of see the spectrum, and there are many, many different other, I've only chosen a few ones to highlight. Now look at the forehead, right? This is a broad forehead, right? Which is a bit distinct from frontal bossing. Who can tell the subtle difference looking at this picture between broad forehead and frontal bossing? Protrusion. There's a little bit of protrusion on both sides, right? तो ये जो है ना दोनों ये and you see this in your patients with thalassemia because of the diploic space in the bone marrow cavity being expanded because of extramedullary hematopoiesis, whereas the broad in general could be just syndromic from other reasons.
this morphology के लिए जो होती है ethnicity specific parameters दिए जाते हैं and familial features के background में आप उसको place करते हैं.
Oh, absolutely, very important. For example, our people from the north, the Hazara community, for example, will have upslanting palpebral features. So we should know that, and we shouldn't immediately say this is unique or abnormal. That is appropriate for that particular ethnicity. Another example is the unibrow or cynophorus. In the Western population, very unusual, but because we have more body hair and more facial hair than them, sometimes we see that even under the usual circumstances. So mid-face hypoplasia is something that usually people will either write in their notes or tend to pick up. It's not appreciated that much on a frontal picture, but if you look at the side view or the profile, you can see very clearly how the maxillary prominences have not come forward like they do. So this is called mid-face hypoplasia, and a number of conditions, including Down syndrome, can have that. Then you look at the cranial morphology, and this is an example of a flat back of the head. If you don't know any term, you can use these simple terms, that's also okay. Just don't use inappropriate terms. So the technical name for this would be brachycephaly. Very good, okay? And this is more of a longitudinal, sort of elongated head, right? I would not call this a American football shaped head. Some references call it. It's elongated, in the anterior-posterior direction compared to the transverse direction. So what is the term for this? Yeah, so this is basically brachycephaly and dolichocephaly. Again, if everyone knows these terms, simple to communicate, simple to use, right? If someone's dolicho is someone else's brachycephaly, that's a problem. So one must know what terms mean and what they use, right? Then let's look at macro and micro, all right? And these are extreme examples, very easy to appreciate. So you can see, one of the things that I notice my junior trainees and students is they'll comment on prominent ears. But that's just a relative thing. When the head is small, the ears will usually look big. So, and always measure, right? Dysmorphology is, most of it is quite subjective. But there are certain aspects which are quite objective, and macro and micro are, right? So anything greater than 90th percentile, anything less than 10th percentile would be macro or micro, right? And there are growth charts. There's actually a huge whole book which has growth charts for all body parts. Yes, Vishal.
इसमें भी 95th centile. So अगर above है तो not all above more than 95th centile will be labeled as macrocephaly. There is also then have to call it as relative macrocephaly or not. Because अगर वो बाकी body proportion 90th centile में नहीं है, सिर्फ head circumference है, तो फिर आप macrocephaly कहेंगे. लेकिन अगर backward movement है, सारे सब कुछ ही सब बड़ा है, तो वो macrocephaly नहीं है. Similarly, अगर आपकी माइक्रोसेफली है तो वो मतलब जब मैं हमेशा उसको बोलती हूँ सिर्फ माइक्रोसेफली कहना काफ़ी नहीं है, उसमें निकालो कि वो एक्वायर्ड है या कंजनाइटल है, फिर उसके बाद नहीं बताओ कि ये रिलेटिव है या
एब्सोल्यूट है,
कॉन्स्टिट्यूशनल है. तो ये बहुत इम्पोर्टेंट है आप उसको मीनिंग देने के लिए. इसका मकसद क्या है? ये सारी चीज़ें पिक करना. पिक करने के बाद आपने अपनी डिफरेंशियल इक्वालॉजी की तरफ जाना है. तो जब तक आप उसको इक्वालॉजी में प्लेस करने के लिए आपको ये डिसाइड करना है कि ये एक्वायर्ड है, ये कंजनाइटल है, या ये रिलेटिव है, या ये कॉन्स्टिट्यूशनल है, तो फिर आपकी इक्वालॉजी डिफाइन.
बिल्कुल. And sometimes you get very unusual shaped heads. So this is a patient with pancreatinosinostosis, and they get this clover leaf shaped skull, which actually there was a German scientist, they described it in German. It's called Kleber-Shuttle deformity. You might see it in old textbooks. So you see a lot of these things, and it's good to be able to recognize that. The ears, you can have a whole session on just ears. And there was a very famous paper that was written by 5 or 6 geneticists. They took their own pictures of their ears, and every ear was dysmorphic. And they described it. So ears, I keep saying ears come in many different flavors. Okay? So most of the variations don't mean anything, but some of them are very stark, and I'm going to just show you some of the stark ones. The most common thing that again we expect you guys to know is whether the ears are low set or not, right? And वो बड़ा एक आदमी low set कहेगा, दूसरा कहेगा नहीं ये वो. So again, there shouldn't be that much subjectivity, right? So the way to do it is that you draw a line from the medial canthus, and that's your horizontal, right? And typically, most of your ear length, about 1/3 is above and 2/3 is below. That's kind of the thing. So when you have the majority of it below this line, you will call it low set ears. It doesn't have to be completely that the ears are all starting below that medial canthus line. And in any facial morphology, your medial canthus is your best friend. That is your relative point, because if you have upslanting palpebral features, by definition every ear will be low set. So you cannot do that. Always use the medial canthus as your relative point. And when I was training, people had protractors and vernier calipers, protractors, and they would measure angles. I think in this day, and especially with our patient load, if we start doing that, then it's going to be not feasible. So I think we cut corners every now and then, but this is again classically showing you that posteriorly rotated ears, how are they defined, how are, this is again this length of 1/3 over 2/3. So it's just good to know where the history comes from and why these definitions are there. So this is quite common, and most pediatricians would have seen this. The majority of these ear pits or tags are anterior, but some can be posterior too, alright? So again, describing this is also a sort of a malformed ear. It's posteriorly rotated, but you've got this unusual structure over here with multiple tags, for example. This is the posterior ear tag. You can see this is maybe what we call a simplified ear. The inner helices are not very well formed. It's a little bit posteriorly rotated, right? You can see a little bit of a bump over here. You can see a huge cavity, quite a significant pit over here. These are very common, and most of them are benign, don't mean anything, right? But sometimes they can alert you to the fact that there may be a renal anomaly, because embryologically the ears and the kidneys go together. So the general teaching is at least look clinically, and if you're suspicious, do an ultrasound to see. Also, I think a lot of pediatricians, trainees as well, are quite adept at commenting on whether there is hypo or hypertelorism, because again, classically syndromes have one or the other. It's always good to know what is the usual situation and what is the unusual situation. So you can tell by the picture, yes, this looks quite wide, this looks quite narrow, but there actually again is actually a growth chart with what is exceeding the percentile limit and so forth. The important thing to know is when you're measuring or when you're looking at the eye spacing, again your interpupillary distance should be the one you look at, right? And that has to be normal for it to be truly normal. And if it's hypotelorism, then the interpupillary distance is narrow, and if it's hypertelorism, then the interpupillary, because there will be situations where you have just the nasal bridge is widened but the interpupillary distance is normal. That is not hypertelorism, and you'll recognize it. So this is kind of just a guide to give you the extreme, and this is obviously a made up picture, but नहीं AI तो नहीं, तो AI से बहुत पहले की बात है. They just merged. But so basically the widest one will be where the space as well as the interpupillary is there, so that's hypertelorism plus what we call telecanthus, and this is pure hypertelorism where the space is between the two medial canthi are normal, but the interpupillary distance is still elevated. And then as you go up, you can see the hypotelorism, and then the most extreme version of this is cyclopia, where you have a single eye, and that can be seen with holoprosencephaly sequence and sometimes certain chromosomal disorders. We have a lot of people comment on epicanthal folds, and some of them can be just ethnic or sometimes can be familial features, but sometimes can be alerting you towards a particular syndrome. So you can see here, you know, the sort of the what we call sometimes reverse epicanthal fold, because it is coming close to the midface and going all the way up also. So these are kind of almost like a semi-lunar type of appearance. So all of these are important to comment on. Once you know what is unusual, then you go the next step and say, what may this mean? This is what I was talking about in terms of the unibrow or the cyanophorus, because this can be alert you to a particular syndrome. I'm deliberately not naming syndromes. I know some of you are itching, you know the syndrome, but the point of the talk is not, we'll do that at the end. The point is describe what you see, right? That is be like the Sherlock Holmes. You know, dysmorphology and Sherlock Holmes go together, putting all the clues, knowing what's important, what's bakwas, and then coming up with your differential. This patient also has prominent eyelashes, as you can see. So then comes the nose, and obviously the nose also comes in many different flavors, but again it could tell you a lot. So we see this, and you can see a couple of things going on. What do people observe? Yeah, the depressed nasal bridge, and the nasal tip seems to be pointed upwards, right? So both things are going on together. And here what's going on? The nasal tip is quite broad, and you can see the spectrum through which it's broad, and some is broad all over, some only the tip is broad. So again, different syndromes will have different signatures that it will come up with. And the way to truly comment on the nasal bridge is to look in profile. Very hard to comment when you're looking at a frontal picture. So again, in your examination, always look from the side. You know, always look from the side. You'll see things that you may not see just up front. And I know that especially in the NICU, you know, when we get these consults, the babies are in their incubators, we're not really, you know, handling them. But if it allows you, take a look, bend down, turn the baby around if you can, see them, and you will see things that you would otherwise miss. So there is no replacement for undressing the baby or the child, no replacement for doing a proper head to toe exam, because that is the only way you will pick things up. Even in the age of AI, physical examination is hugely important. Chin is very important, and you can see this could be a pointed chin, it could be micronathia or a very small chin, and sometimes it gets confusing. What is the difference between micronathia and retronathia, right? So by definition, retro is piche, right, backward. Sometimes you get a combination that it's backward and small, so you can call it retromicronathia. But if it's relatively normal size but just posteriorly located, then it's retronathia alone. Alright? Alright, so now is going to be the fun part. We're going to talk a little bit about approach, and I said, at least on the face, let's have an organized approach. So the first thing to do is get a overall feeling of what you are seeing. This is called the gestalt. Get a picture. Is the face looking dysmorphic or not? Is there something that immediately strikes you? You know, rounder face, longer face, that kind. Then you start looking at individual components. Start with the head, Do the head circumference. I think you have to, either your nurse should have done it for you or you have to do it yourself. But you have to do a head circumference when you're doing a dysmorphology exam. Comment on the fontanelle, obviously, especially in the younger kids, and the hair. Ear, size, position, shape, and at least, and sometimes in dysmorphology it's also important to know what's not present. Because you can say this is, the patient has a heart lesion, but there is no cleft palate. That has its implications. Because if you don't write anything, I don't know whether you examined the palate or not. So that's kind of stuff. Eyes, as we mentioned, nose, just very, very, kind of big things. So, if you use this framework, it's less than a minute. अगर आपकी आदत हो जाए ना, this shouldn't take very long. So it's just a matter of being organized and going from top to bottom and not missing anything. Sometimes you see the eyes and you stop over there. And you say, oh, eyes are unusual or upslanting, and then you don't comment. So whenever someone is presenting a case where suspicion is trisomy 21, I ask them about all the other things, and usually people have missed 3-4 big things because they just looked at the eyes and stopped over there. And it's kind of like putting a puzzle together, right? Once a few pieces come together, then you have a hypothesis. ये तो यहाँ लगना चाहिए. So then you start looking for things that you may normally not look at, right? So for example, a good dysmorphologist will look at everything regardless, but again, there are very few who would claim to be good dysmorphologists. I'm certainly not one of them. Fifth finger clinodactyly. It's a kind of a non-specific dysmorphism, can be present in healthy people, can be present. But in the context of upslanting palpebral fissures, malar hypoplasia, low set ears, protruding tongue, short neck, nuchal thickness, if someone else tells me this is also present, it adds something, it adds some value, because then same thing with the sandal gap. It's not that important when all these other things are not there, but that becomes important when you're thinking of this syndrome. So connecting the dysmorphic features together is something that is expected of you guys. Okay, what would you say about the shape of the face? Huh? Roundish, right? Yeah, you do get that sense that it's a bit of a round appearance. ठीक है? ये आ गया. Now let's go to see that fine hair that again comes, it's a subtle feature, may not be present in everyone, but kind of goes a little bit. If you're looking for it, then you start putting the clues together. All right, do you see smaller ears, low set ears, right? Kind of comes up that way. What about the eyes? What do you guys see in the eyes? They're relatively small, fine, and yeah, I guess the interpupillary distance looks a bit big. And upslant. Can you guys appreciate the upslant? Always remember Down syndrome, upslant. ठीक है? Ulta. So that's a good way to remember it, right? ये हो गया. Epicanthal folds भी हैं, kind of hidden in. Again, the projection is not very good, I'm sorry, but you can see it. And then again, not the best view to comment on depressed nasal bridge, but now that you're looking for it, you could potentially look for it here, right? So here diagnosis is clear. Do you need a karyotype in this kid to confirm the diagnosis? This is one of my pet peeves, and I'll tell you why I'm saying it. So I go to the NICU, suspicion is trisomy 21, and they say, हमने family को कहा जब test आएगा ना फिर हम आराम से आपको बताएंगे. And I told the neonatologist, this is a clinical diagnosis, right? You don't need a karyotype. Why are you making the family? मैं कहता हूँ कि जो जितने आयतल कुर्सी के विरद होंगे ना उन 3 हफ्तों में कि अल्लाह करे ना आए, अल्लाह करे अल्लाह करे ना आए, और फिर जब वो आएगा they will crash to the ground. So I feel that there is an inherent fear in the pediatricians to have that conversation. And that fear says, yaar, abhi nahi, baad mein thodi si aaram se. And part of it is they say, yaar, the family is going through so much. Because NICU mein the baby is there for some other reason also, right? Koi respiratory distress hai, koi heart hai, kuch bhi hai. So they say, let them deal with this immediate stuff. We'll deal with the Down syndrome later. But you can't do it later, right? So when you make a diagnosis, then the person making the diagnosis, once it's confirmed, you get the experts involved. It is the job of the team to confront the family with it if the scenario is appropriate, right? And वो हमेशा माँ को नहीं बताइएगा, माँ की अभी तबीयत बहुत, माँ से तगड़ा दिल किसी का नहीं है दुनिया में, right? माँ को हम credit ही नहीं देते हैं. Everyone sidelines the mother. So I'm sorry I'm taking the side, but this is my pet peeve. कि अगर Down syndrome की diagnosis बन रही है clinically, please do not wait 3 weeks for karyotype. The karyotype is not done to confirm the diagnosis. That's only about maybe 3-5% of cases जहाँ थोड़ा बहुत doubt हो, prematurity हो, you're not quite sure, you're doubtful. 95% cases is slam dunk. You know the diagnosis. You need it for recurrence risk. कि जी वो ये ट्रांसलोकेशन है कि फुल ट्राइसोमी है. So, you know, in most cases you don't need it. Okay, you guys will come to the diagnosis. You'll know what this kid has. But let's break it down. Shape of the face. क्या? हाँ? थोड़ा सा broad, but there's something else kind of shouting out at you. हाँ, थोड़ा बहुत elongated है. Agreed. Triangular would be a good way to describe. Especially chin is quite, you know, pointed. So triangular आ गई, ठीक है. हेयर कर्ली से हैं थोड़े से, राइट. अब पता नहीं एथनिसिटी क्या है, वो है. आईज में क्या नजर आ रहा है? थोड़ा सा ग्लासेस अगर नहीं होते तो और बेहतर होता. आई शुड यूज अ बेटर पिक्चर नेक्स्ट टाइम. थोड़ी सी टोसिस है इफ यू लुक वेरी वेरी केयरफुली, राइट. एंड हाइपरटिलिज्म आपने बताया था. आर यू नोटिसिंग something else about the gestalt? Would someone be bold enough to describe this as coarse? It's a relative term.
I'll look at it.
I know, but हम जो coarse देखते हैं ना storage वाले, ये वो वाला coarse नहीं है. But there is a little bit of blunting around the nose and around the cheeks, right? So you know, this is happening here. Ptosis, epicanthal folds हैं, prominent columella है. You see how the you know thing was coming down. थोड़ा सा wider nasal root है. If I were to tell you that this patient has pulmonic stenosis, would that point you to a certain diagnosis? That is a very classic heart lesion in this particular condition. Dr. Femina already knows the answer. She's deliberately staying quiet. Okay, and if I say there was a webbed neck that this patient had, Turner में facial dysmorphism almost negligible होता है. No, this is Noonan. ठीक है ना. तो Noonan pulmonic stenosis is a very classic lesion for Noonan. जो Turner syndrome है ना, उसके अंदर mainly जो आपका होगा वो coarctation of aorta होगा. Right? So ये सारे एग्जाम के क्वेश्चन हैं, ये चीज़ें आती हैं इस तरह की. They want you to pick up those clues. All right? So this would be Noonan syndrome. Okay. एकदम से सब चीज़ से क्या क्या नजर आता है? Ears, right? Prominent ears. अब let's move beyond the ears. और क्या नजर आ रहा है? थोड़ा सा, at least this patient has a bit of a longer face. ठीक है? थोड़ा सा relatively large mouth, but quite बाकी चीज़ें certainly, but the long face and the prominent ears are there, right? तो अगर हम कहें कि intellectual disability है दोनों लड़कों को, क्या है? जोर से बोलो. Fragile X, right? Because the prominent ears with intellectual disability and long face. ठीक है? विलियम्स का different होता है, वो भी आएगा अभी. Okay. इन दोनों चेहरों में क्या सिमिलैरिटी है? एक बहुत छोटा बच्चा है, एक थोड़ा सा बड़ा है, बट व्हाट इज काइंड ऑफ क्या चीज? सो दे आर बोथ स्माइलिंग. चलो गुड. हाँ, हैप्पी तो हैं, और हैप्पी इस वजह से लग रहा है कि माउथ इज एक्चुअली रिलेटिवली लार्ज. हाँ, अच्छा, ओके, आई एम सॉरी, आई डिडंट हियर दैट. सो इन बोथ केसेस द माउथ, स्पेशली द कॉर्नर्स ऑफ द माउथ, आर क्वाइट लार्ज. और क्या? हाँ, when you're lost, start from up and go down. Okay? यहाँ forehead चलो ठीक है, थोड़ा सा हल्का सा टॉल. Look around here. What's happening around the eyes? यहाँ हाँ थोड़ा. Would someone call this periorbital puffiness? ठीक है ना. तो ये तो है. अगर हम बहुत closely देखें शायद आपको stellate pattern मिल जाए iris में. ठीक है. फिर you can look here a little bit, the you know थोड़ा सा nasal bridge यहाँ लग रहा है, यहाँ prominent है, यहाँ सही है, तो maybe that's nothing, but slightly upward pointing tip here, यहाँ इतना नहीं है, but slight, again very very slight coarsening, which is very subtle, probably not worth commenting on. Wide space है between the teeth, periorbital fullness, slightly short palpebral fissures, large lips and so large mouth. This is Williams syndrome. ठीक है ना. वो happy kids, they have this, you know, their verbal skills are beyond their comprehension skills, so that's it. All right. यहाँ एकदम से क्या क्या चीज़ स्ट्राइक करती है? आइज में क्या नजर आ रहा है? What is the thing that immediately looks a bit unusual? Eyebrows arched है ना? Arched. They may not be very hairy or very bushy, but they're certainly high arched. और अब पता नहीं सो के उठाए क्या हुआ है, लेकिन थोड़े से unruly से बाल हैं. You know, usually kids of Caucasian descent have fine hair, so this looks a bit unruly a little bit, right? Even the eyelashes यहाँ पे अच्छे नजर नहीं आ रहे, but a little bit prominent. And this is what I would call a sort of a sharper nasal bridge. थोड़ा सा sharp है. Nasal हाँ tip. ठीक है. There is this again very subtle coarseness around here. हाँ, माइक्रोसेफली मैंने लगा दिया है, बट जाहिर है मेजरमेंट के बगैर और इस व्यू पे बताना मुश्किल है. लो सेट ईयर्स हैं, देख सकते हैं आपके. इवन ऑन फ्रंटल व्यू यू कैन टेल के लो सेट हैं. प्रोमिनेंट एंड पॉइंटेड टिप एंड लॉन्ग फिल्ट्रम, स्मूथ एंड थिन अपर लिप, राइट. तो ये क्या सिंड्रोम है? इंटेलेक्चुअल डिसेबिलिटी, हाँ, कॉर्नेलिया डी लैंग सिंड्रोम. वेरी गुड, ठीक है ना. So this is it. So I think I'll conclude because there are hundreds of syndromes. We can't go through everything, but this is just the beginning. And if people want, we can have an in-depth session on more syndromes and features. I have a good compendium of pictures. So conclusion is ke organized approach, using the right terms, being comfortable, and it's a learning process. There's a whole conference. There's a dysmorphology, Smith's conference कहलाती है. वो सिर्फ dysmorphologists जाते हैं उसमें. And वो measurements करते हैं, and they come up with terms and they come up with certain things. I mean, it's a whole different field in its own right. I don't know in the age of AI कि उनका क्या होगा. But I mean, I remember someone told me they trained with someone जो के columella की length, columella sorry, जो ये frenulum है ना, उसकी length measure करते थे. I mean, can you imagine how long one exam would take? But there are people who treat it as a science and take it very, very seriously. ठीक है? So I would call it an art, but it is evolved into a science and treat it like a science. Make it a bit objective, make it organized, and technology will not replace you. Don't, I think ये बहुत ही एक हर चीज़ में in general I think you can say that अगर replace करेगी ना तो बकवास चीज़ों के लिए replace करेगी. बड़ा अच्छा होगा कि आपको बकवास टास्क नहीं करने पड़ेंगे. Do the higher level tasks, be up to it, expect more of yourself than just the usual things. And again, if you suspect, ask for help. Part of it is technology help. We are always available. I think every institution should have someone who is an expert dysmorphologist. It may be a senior pediatrician. Ask them for help. Again, with consent, send pictures. We're happy to give a comment and see, right? So stopping over here and happy to take questions. We have a few minutes before we can end, I think. Thank you.